In this case, a man of faith placed far too much faith in a chatbot and not enough faith in the concerns of his church members and family.
Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. This is our Hot Topics show and I'm your host, Louise Shaver.
And I'm your other host, George Margellis.
George, how are you today?
Hey, it's pretty good. Another sunny but chilly day here in Sydney. It's been a fairly good couple of weeks since our last Hot Topics call. Lots of interesting stuff happening, keeping ourselves busy, kids, families all well. How about yourself? How's life in sunny, and I use the term loosely, Melbourne?
Yeah, it is a bit like that. No, it's good. We do get the sun here, actually. Even now, it's quite bright in my office. I had an interesting experience with ChatGPT, which, yes, you unfortunately got the worst end of the stick. So I thought I'd tell listeners. I use the AI tools that we're always talking about. So I use them as well for all sorts of things. But on the theme of keeping the human in the loop, I had put all these URLs for different stories into ChatGPT and worked through the stories. And anyway, and I said, oh, look, I just need to send George an email. So could you just come back to me with the summary of these are the hot topics we're going to talk about with the URLs? And I sent that email off to George. And then late last night, poor George, you're sending me an email going, most of those links are not working. And when I went back to ChatGPT, I was like, hey, you got most of those URLs wrong, even though I gave them to you in the first place. And this is its response. You're right, Louise. I'm sorry. I replaced several of your exact URLs with guessed alternatives. And some of those guesses were wrong. That was careless, particularly when the purpose was to give you something reliable to send to George. And then it listed off its errors and said, I actually should have preserved every URL you supplied verbatim and verified every additional link before including it. Anyway, now I use these tools often. It knows what it's supposed to know in its memory. Don't ever lie to me. Don't ever confabulate. Don't make shit up, basically. Like, I need to know when I'm having a conversation with you that it's accurate, and it completely stuffed up. And of course, this was a small thing, which George unfortunately did impact you, and I apologise. And yeah, I've had words with ChatGPT, but at the same time, I thought it was a good story to just share at the start of the pod, considering we talk about AI use in healthcare a lot, where the stakes are much higher if mistakes get made.
Look, it did have me a little concerned when I was clicking on these links that you sent me. That I was actually babysitting last night. So I was doing that while babysitting little Evie. And I thought, oh, why aren't these links working? Is there something wrong with my computer? So I actually tried on my phone. But yeah,
they looked real.
They look, and again, that's part of the challenge, isn't it? What AI tells you looks very convincing, and it does a really good job of it. And when I came up with these 404s, I thought WHO had been hacked or something. Yeah, I wasn't quite sure what was happening.
Oh, no.
Yeah, it was an interesting experience. I use Gemini here a lot for the AI tool, and it often comes up with the thing at the bottom, these answers may be wrong. And I sort of go, why am I paying you $24.99 a month if you're telling me your answers may be wrong?
Yes, well, we're going to talk about that as a theme in one of our stories today. Yeah. But yeah, I always check everything it gives me with links to the outside world. But because I had given it the URLs, it didn't even occur to me to check. So mea culpa, my mistake. I apologize, George, but also warning and also, yes, human fallibility as well as AI fallibility. But anyway, it now has promised me it won't make those mistakes ever again, but I will be checking from now on.
But it was very polite in its response to you. So it did admit it. So, it didn't try to hide it. But again, good highlight.
What's Sam Altman up to over there at OpenAI? Like, how's their tool getting worse? Got a lot of money.
And there has been some interesting discussions lately about the fact that as we train these tools on more and more data, it doesn't necessarily make him more and more accurate. But look, it's been an interesting week. We've obviously had the big announcement around the AI healthcare roadmap that we had Enrico on 24 hours after he announced it.
Which has been a hugely popular episode, actually. It's gone global big time.
Yep, I've had a couple of comments over the weekend. And I'm getting ready to go to Hong Kong. And of course, Hong Kong had a typhoon over the weekend. So that makes my my travel plans interesting. So I'm looking forward to a very wet and wild week in Hong Kong in the next couple of days, followed, of course, by Hick in Sydney.
Yes, we will. Although we're going to catch up for drinks to keep you entertained before you go to the airport. Is that right? On Wednesday?
Absolutely. We're going to see you in Melbourne for the upcoming Sparked Aged Care event and the Sparked events there. So there's lots of stuff happening here in Australia. So we should jump into the podcast and get these hot topics rolling.
All right, let's do that. We're opening today on trust because two stories this fortnight, one on each side of the Tasman, tell you exactly how fragile this trust is. So here in Australia, Partnered Health, a network of more than 60 primary care and skin cancer clinics, it's owned by private equity firm Quadrant. They confirmed that a malicious actor took patient data from 21 of its clinics across 5 states and territories. Not just names and Medicare numbers, although that would be bad enough, consultation notes, referral letters, pathology results. And the company became aware on the 23rd of June, but it told patients on the 15th of July. That's a 22-day gap. And then meanwhile, in New Zealand, Health New Zealand has just released a 19-priority action plan to strengthen digital security across the health system. As reported by Reece Lyon in Pulse IT, the plan is in response to the reviews into the Manage My Health breach that happened in December last year, where the New Zealand Privacy Commissioner found that both Manage My Health and Health New Zealand failed in their responsibilities to have reasonable safeguards in place to protect patient information. Now, the action plan includes significant changes to procurement to manage supplier risk, including classifying suppliers according to their risk and creating a register of suppliers that store or process sensitive health information. George, do you think we need to look at cybersecurity as a risk to patient safety and deal with it that way, in a similar way as we deal with clinical safety incidents?
Look, cybersecurity seems to be the topic that just keeps on keeping on. I think we first discussed it at HIC 15 years ago, and it's obviously getting bigger and scarier as we go forward. This latest breach is quite interesting. Normally, they're going after a government department or a multinational, but a group medical practice, which, to be honest, up until this breach, I had never heard of as a target, is an interesting sort of pivot. We do know that there's been a lot of sort of smaller hospitals and aged care facilities hit by ransomware attacks, but this seems to be a breach to actually pull information out of it. And from what I understand, there doesn't seem to have been any threats of locking him out or whatever. You'd have to assume 60 practices, they'd have some sort of security system in place, but as we've seen from many of the breaches, the security you have is never enough. And that's why the New Zealand report's quite interesting, trying to formalise the security models that people use and provide some sort of standards around that's important. And to the defence of our people in Australia, the National Cybersecurity Coordinator is actually a general in the army. And the Australian Signals Directorate, despite its relatively boring name, is a big deal. They're doing a lot of work in this space. But as fast as we do stuff, then the bad guys do things faster. And it's also become a bit of an AI battle because the bad guys use AI to make their cybersecurity threats bigger, and the good guys use AI to make their cybersecurity defense bigger. And as a result, we spend $7.5 billion in Australia on cybersecurity. I mean, that's a big chunk of the money that gets spent on stuff that doesn't provide any net benefit other than the good guys and the bad guys fighting it out at a cyber level.
And this is an ongoing issue. I believe there was 1,205 breach notifications in Australia just in the 2025 calendar year, and that was up 8%. And it was the highest they'd ever recorded. And out of those breaches, it was actually health providers were the most notified sector, with 19% coming from health, with 225 incidents. And it's very interesting what New Zealand is doing, because to actually look at the supplier risk. And so now if you supply any software, if you're a startup or whether you're a big EMR vendor, you're going to be rated by New Zealand on what your cybersecurity risk is to the New Zealand populace. And that's going to potentially change procurement, not just guidelines, but the actual outcomes of procurement as well. And I thought that was a really interesting stick, let's say, for the government to use to encourage better practices amongst the vendors that healthcare work with.
Look, you have to make the assumption that most vendors are going into this space doing their best to make their software secure. But the reality is, we saw when they released the original Mythos from Anthropic that it did a really good job in finding loopholes or gaps in people's security. So like I said, it's a continuous battle of good guy versus bad guy, and we just need to try to disincentivize the bad guy and support the good guy where we can.
That's right. And we'll put a link to it in the show notes, everyone, because these issues are of relevance to everyone working in healthcare. But in New Zealand, they have the Health Information Security Framework, which is sector-wide security framework, and it's got compliance thresholds against it. Australia's got, this amazing Australian Signals Directorate, but I don't think we have an equivalent here. A lot of countries don't have something specific regarding cybersecurity for healthcare. We take a more generic approach across all industries here. So anyway, it could be interesting for people to have a look at as well. So I'll put those links in.
Look, I have to say, every health technology conference I've gone to in the last 5 or so years has had a significant cybersecurity component to it. I have to admit that I tend to glaze over as I listen to the talks because they are very technical and they are very good. But again, the fact now that any organization needs a chief information security officer, that's an extra expense to the organization, an extra level of governance in a healthcare system which is already stretched to utilize its resources. So yeah, hopefully we'll find a solution to this. Otherwise, I think we'll be quite a horrific future forward where our greatest concern about everything is the security around it.
That's right. And we don't want for privacy advocates to lobby for actually we shouldn't digitalise and let's stay with paper because of cybersecurity. And it's a whole ethical debate we don't have time to get into today, but something worth acknowledging. We certainly don't want to hold ourselves back, but we need to ethically carry the risk and deal with it well. Okay, well, let's go over to Europe now, George. So from trust to readiness, the World Health Organization has released its first Europe AI Readiness Assessment report, and it provides one of the clearest pictures yet of how well prepared countries are to safely implement AI in healthcare. WHO also just held a global AI conference where the regional director for Europe, Hans Kluge, warned that only, hold on to your hats, people, only 8% of countries in the WHO European region have a health-specific AI strategy, 8%. And if you hold that against what's actually happening, so nearly 2/3 of those same countries without AI strategies are already deploying AI in diagnostics, and half have introduced AI-powered patient chatbots. So basically, we're deploying a technology that is going to reshape and is reshaping medicine, but 11 out of 12 countries have no strategy to govern it. Now, AI readiness depends on leadership, governance, regulation, workforce capability, public trust, data quality, digital infrastructure, and of course, evaluation. And Dr. Kluge calls out that gap between deployment and governance is probably the defining challenge of AI in health right now. And we've seen it's a very strong theme in Australia's AI roadmap, as Enrico spoke about in last week's episode. So, George, look, we can't look at Europe for the answers. The US is probably never going to regulate AI. Ireland, as we covered in a previous episode, is one of a few countries that have actually published a full national AI for care strategy. We're really going to have to get our skates on and address this, which is also really the key message of Enrico's roadmap.
Yeah, so it's interesting. We've been talking about digital maturity in healthcare for quite a while, but the reality is the AI component wasn't really part of that discussion. We used to talk about our infrastructure and our IT governance, but the AI has come across us at such speed that we just aren't prepared for it. Now, to the Europeans' credit, they're actually measuring it. So at least they're actually starting to have these discussions. Like you said, in the US, they've stuck their head in the sand and said, don't worry about it. We've seen some of the net effect of that. The fact that the European Union now has active research in place looking to see which countries do have this. And yeah, Ireland is a European country, so maybe they will become the leader in this space. And the report, I highly commend it to people. It does go into a lot of detail about what AI readiness is, understanding the core complexities. And one thing they do highlight, of course, is that AI is part of everything we do in society nowadays. Healthcare can't be held in isolation. However, at the same time, healthcare does have its unique complexities that need to be taken into account. And making sure that the national strategy and the local strategy and the healthcare strategies are aligned rather than trying to have them competing against each other for visibility is important. The problem here, of course, is producing yet another policy document that tells us how to use AI rather than training people or educating people about the AI is a problem. There are a plethora of policy documents. Ultimately, it comes down to having a well-trained workforce who utilizes AI and recognizes its potential benefits and its potential risks, and being able to balance those in a satisfactory way. It talks about regulatory fragmentation. If every state, every local jurisdiction has its own set of AI rules that don't align, then we'll just have the ultimate finger-pointing exercises. Policy A said this and I'm doing it, and policy B says the opposite. Legal liability often becomes the de facto metric we use for AI being misused, but outside of legal liability, there's social responsibility for what it does as well. And then we also need to take into account the extra financial costs associated. but also the environmental costs. There's so many issues in this paper. I think the Europeans are definitely worth watching. Question is, we're doing it after the fact. Has the horse bolted is the question people will ask.
Oh, yeah, and it really is. So as Enrico said, we've got to get our skates on. The EU has their AI Act, which is now in place, but it just shows that it doesn't substitute for health sector governance because fewer than half of the countries, the report showed, have assessed whether their legal frameworks are even fit for purpose. 40% still have no ethical guidance on AI in health. And then on your workforce comments, George, this was higher than I expected, but only 1 in 5 countries provide AI education to health professionals before they qualify. So when they're at uni, only 1 in 4 offer training once they're in the workforce, and yet they're already using these tools. This is not future stuff. We're using it, but we're not training people. And Kluge's formulation I thought was really important. And he said, a clinician trained to trust a system they can't interrogate is not empowered at all. They're just exposed to mistakes outside of their control, which is scary.
And the other big thing obviously happening in Europe is European health data space. So they're actually working on amalgamating their health data across the entire region and using that as a tool for ongoing research. But that also opens up a series of new risks as well. Yeah. I've been over to Europe a couple of times in the last couple of years because, to be honest, I'm scared to travel to the United States in case my Facebook post gets seen. But that's another story. And I have been very impressed by the level of discussions that are being held over there. So I think this is an opportunity for Australia to align ourselves with an area which has probably more in common with our healthcare system than other countries do. And people like our good friend Geordie, who's now running Open Air, I think that's an opportunity for us to align ourselves. But we need to be having serious discussions. We've seen Enrico's work's been fantastic and the AI Alliance, but we can't let this get past us and then try to mop up the mess afterwards. That produces a series of challenges we don't want to get ourselves into.
Absolutely. And a good callback to our interview with Geordie as well, because he talked about interoperability theatre. And there's really an equivalent here with AI governance being AI governance theatre. And we don't want theatre. We need real ethical frameworks that are abided by and proper governance. So no doubt this will be a theme we continue to come back on, and well done WHO for the report. Really well worth reading. We will put a link to it in the show notes. All right, now let's look at the money now, George. We love talking about money, but it is this time of the year for us to check in with Rock Health's report into the investment dollars flowing into US digital health startups. And by the way, we do care about global, not just US, but the US have this great report that comes out every quarter thanks to Rock Health. We could think that maybe it's equivalent across the world, but I imagine the dollars would be way less in other places. Well, the US found that $7.4 billion of venture capital money was raised in just the first half of 2026. And that is $1 billion up on last year across the same number of deals. So let's look at where it went. There were 20 mega deals, which took 45% of all the capital, and just over 8% of deals absorbed nearly half the money. And of course, we mentioned this before last time we looked at Rock Health's report. They don't even label companies as AI enabled anymore because it no longer distinguishes anything. Now, we put the Rock Health numbers against a systematic review published this month in Health Policy from Elias Mosoyalis' team at the London School of Economics, spurned on by claims that AI is supposed to save healthcare hundreds of billions of dollars every year. They went looking for the evidence, and they screened almost 20,000 sources, and they found only 91 studies covering 98 economic evaluations of AI. And they're finding there is good evidence of economic savings in diagnostic AI, with reported savings anywhere from $3 to just over $2,500 per person. But that's not billions. But they also failed to find a single instance of economic evaluation of generative AI. 0. And then we also have a report from the W Group into global women's health investment. And they found $1.55 billion of investment across 85 companies. But they found that investment into Series A and further is really tough, mostly because VCs don't understand the investment category, a theme of lack of investment in women's health we have covered before on the pod. But one commentator even suggested that founders will get further with generalist VCs by calling it infrastructure and dropping the women's health label altogether. And Jerry Stengel has a great piece on this on her Substack and also in Forbes, which I will put a link to it in the show notes. George, do we see here that capital is following evidence or excitement?
Yes, digital health investment booming. It's not quite at 2021 levels, but it seems to be on an upward trend. And from a financial perspective, that's probably a good thing. But I've often said it, and I'll say it again, I don't think investment spend should be an indicator of success in digital health innovation. I've seen too many examples of very well-funded duds. The word Theranos comes to mind, that aren't really innovations or aren't even really real. And if the key focus is the amount of money raised versus the outcomes, we have a challenge. And whilst it is getting better, we haven't seen recently any of those sort of fantastic stories that get their own Netflix series named after them. The reality is there's a lot happening in this space which probably doesn't classify as innovation. And one of the key things, and the report highlights this, that often what they're calling innovations are really just repackaging of old ideas. The number of GLP-1 digital clinics is a great example. You saw eucalyptus here, they got a lot of money thrown at them. But there seems to be a plethora of GLP-1 related online weight clinics to choose from. And that obviously means there's a lot of demand for them, but are they differentiating themselves in a clinically relevant way? Are they providing a better service, or are they just providing a more accessible or a cheaper service? And what often happens is that as they have this huge competitive threat against them, do they have to cut their prices and then cut corners to make sure they can still be profitable? What's next in GLP-1s? Is it going to be a corner vending machine where you pick up your injection and...
Oh, well, your pill, actually, instead of your injection.
And then it becomes a pill. So the good news is the sector is getting more mature. We are hearing about more startups talk about outcomes, and not just their financial outcomes, but the patient and healthcare provider outcomes. And we are seeing successes in non-clinical uses, in particular, things like insurance optimization, or that lovely United States term, revenue cycle management. You know what revenue cycle management is?
Sorry, I'm asleep.
Basically making sure they can squeeze as much money out of the patient or insurer as possible. Where is there some free money in the system that we can get our hands on? So it is a worrying trend that we focus so much on capital raises, and we see so much press about that. But in a capitalistic society, I guess the money is an ultimate indicator of success. I thought that paper by Elias Massialos was quite interesting because he looked for the real evidence of economic benefits. And even though in the AI world, a relatively old paper, it is a 2025 paper, what are economic benefits? I remember a head of a fairly large area health service tell me that cost savings in healthcare was always a challenge, because if they improve the delivery of their services, they just had to deliver more services because there's an unlimited demand for services. So we need to start rethinking about how we measure the successes of our healthcare ventures beyond just capital raising.
Yeah, absolutely. But we also cover it on this show because in healthcare, we don't talk about money enough, I think. And we really do need to look at not just where the demand might be coming from. And there's a lot of bad investments, way more bad ones than there are good ones in the digital health sector. But money tells us what we're prioritizing. It tells us where healthcare business models might need to move to or steer away from, as the case may be. Governments traditionally, what they fund in healthcare hasn't changed a hell of a lot in 50 years, and we tinker around the edges. But then you've got this massive, as you said, George, consumer demand. According to Rock Health's data, GLP-1's weight management, that was actually the second. It was actually mental health was the top funded indication. There's so much data that shows how damaging social media has been for an entire generation, for almost everybody, and the disruption it has done in negative ways to society. But now we have all this money going into technology companies to help people with their mental health. We've talked about the mental health stuff a lot on the pod. We've got some guests who will be covering this in future episodes. But I just think it's worthwhile we look at the demand curve for healthcare modifying as a result of these technology-enabled information sharing or access to prescriptions, whatever it might be.
Interesting business model, isn't it? So you make billions of dollars providing a service which affects people's mental health in a negative way, and then you make billions of dollars providing a service which helps you heal those affected mental health services.
And making money from advertising those services.
And it's interesting because when you look at a lot of the mental health services available online, they focused on where the burden of mental health is, or are they focused on that worried well market who is happy to pour money into it, but not necessarily showing a societal benefit? The mental health space is a complex one. I don't claim to be an expert by any means, but we've seen a plethora of ADHD clinics pop up, and everyone I know over the age of 55 has been diagnosed with adult onset ADHD. It's an interesting world we live in.
Oh, that's right. It's time for a quick break, but when we return, we're going to be discussing what patients actually want from AI and the lawsuit that's asking a court whether a chatbot practiced medicine. Back soon. Welcome back, everyone. We talk constantly on this pod about patients using AI. And this fortnight, we have got two very different windows into what that actually looks like. Now, back in April, we covered a Nature Health paper from Microsoft, 600,000 co-pilot health conversations, the 2 a.m. calls to ChatGPT to have these conversations, where 1 in 7 questions were asked on behalf of someone else. That same team from Microsoft has gone global. They've released a new Nature Health paper, and this time they've looked at 1.7 million de-identified health conversations from Copilot across 109 countries. And the standout finding isn't the volume, it's the predictor. The single strongest driver of how intensively a country's population uses AI for health, it's not GDP, it's not internet access, it's not even AI readiness, it's low public confidence in hospitals. Where people trust their hospitals less, they ask AI more. For countries with stronger health systems, the AI use is used differently. So it's used for things like navigation, administrative tasks, rather than simply seeking health information. And the second report we have is from the Commonwealth Fund. Now, they did something on a much smaller scale. They interviewed 23 consumers in New York City and rural Virginia and asked them in-depth interviews with these primary care patients about their use of AI and what they think of AI use in healthcare. And effectively, the patients said that they feel that it's inevitable, but they definitely do not want AI to replace the doctor. And also commented that no one has asked them about AI being used in their clinics. Having AI used in healthcare, which is becoming a universal thing, particularly with scribes, that no one's asked patients, they're just being told. So, George, one of these studies has 1.5 million data points. The other one has only 23 people, but I think they're both very useful. What are your thoughts?
I agree. They're both very interesting papers. And I must admit, I'm a big fan of the Commonwealth Fund. I'm also a big fan of the Commonwealth Games. And did you see the King come out of the TARDIS on the weekend at the launch of the Glasgow?
What?
Yeah,
No.
So,
I'm going to have to go and watch that after this.
Yeah,
I missed it.
King Charles is pretty cool when it comes down to these sort of things.
I love it. I'm a big Doctor Who fan. Oh, that is so cool.
But, and for those who don't know, the Commonwealth Fund has nothing to do with the British monarchy. It's actually a US organisation formed in 1918 with a broad charge to enhance the common good. And it does some amazing research work in healthcare. And obviously they've been listening to our podcast because they decided to look at the patient's perspective. We've only been beating that drum for the last 2 years. So it's good to know that the folk at the Commonwealth Fund are listening to our podcast and driven their interest. And it came up with some really interesting findings. Sure, it's a relatively small sample, but they do quite detailed and in-depth research. So I do have confidence in their work. Not that I don't necessarily believe that 1.7 million de-identified health conversations by Microsoft are in any way biased by the fact that the author of the papers are all Microsoft employees and Microsoft provides the platform and Microsoft.
Yes, that's right.
But even then, the mere fact that they're reporting on that information, I think, is a benefit because we just don't know in detail what people are asking. So having access to that information, I think, is a good thing. And that correlation that the less you trust your system, the more you trust AI to give you an answer is almost a sign of the desperation of failures of healthcare systems. Now, the interesting points out of the Commonwealth Fund that people want to have a say in what happens, but they almost believe that the AI will be there irrespective of what they do. Reminds me of the famous quote by Ken Jennings on Jeopardy after Watson won the game when he came out and said, "I, for one, welcome our new computer overlords." Is that the situation? Are we just acquiescing to the fact that AI is going to take over this space, so we need to work our way around it? It goes back to that earlier discussion about AI readiness. We need to understand what this AI is. Clinician de-skilling is a major issue. There was a recent paper which talked about clinician non-skilling, the fact that medical graduates are not learning some basic skills because they just assume the AI will do that for them. These are the sort of things we need to start worrying about. And then the efficiency gains. We've seen papers which extol some amazing efficiency gains. And then we see other papers that come around and say, actually, it's not as good as it sounds. And in actual fact, it's caused extra burden on clinicians. The particular paper from the Commonwealth Fund looks specifically for primary care. Are we comparing the AI tools to what's an already broken system? We know that primary care is struggling for resources, struggling to get people to engage in it. I went to a dinner during the week and I met a guy, and his father had been a GP in regional New South Wales for 50 years. His father's now in his late 70s. And so I said, is he thinking of retire? He goes, no, it hasn't even crossed his mind. He loves what he does, but he practices medicine the way he wants. He has a small practice. He knows all his patients. He's looked after them for 40 or 50 years. And the interesting comment the son made was that his father doesn't even look at the accounts of his practice. His wife manages all those. He just worries about practicing medicine. So how do we revert back to that system of medicine where it really is around personal care? Does AI help us get there? Does AI hinder us? I think it can do either. So it's really up to us to redesign the system in such a way that we can use AI as that supportive tool that it has the potential to be, and not that replacing tool that we fear it could be.
Oh, 100%, George. The people, they want AI, they're happy for AI to be used, but they want it to be an extension and to help their clinicians, and they want the compassion from humans. So I thought that was really good news. People do not want their doctors to be replaced. But at the same time, I do think that there's an amazing opportunity for clinicians who are under a huge amount of stress from workforce pressure to actually use these tools to help them be able to have the time to be more compassionate and to be more human in their relationships with their patients. An example is my mum is really upset at the moment because she has hurt her shoulder. And so she was catastrophizing on the phone saying to me, oh, I can't even do my laundry. I can't, I think it's a rotator cuff injury. So she can't lift up above. And she wasn't really sure about what she can and can't do, but she knows she's in pain. And I said, what did the doctor say? And she goes, oh, I've got a report, but I don't understand it. And anyway, so I asked her to send it to me, and with her permission, I uploaded it to an AI tool and triple checked everything before I sent it back to mum. But what I did is I just said, look, could you, for my mum, and I said, this is my mum's concerns, could you please write out of everyday language, one pager about what's happening to her body and what she can expect in terms of recovery, and then what she should and shouldn't do. And it did that so well. It even put pictures in there, which I didn't ask for. And it was formatted nicely. It looked very friendly. And then it actually said, would you like me to put another one together which talks about actually exercises that she can do? And I was like, okay, great. So I sent my mum back these 2 one-page documents, and I said, look, I've had AI do it, but I said, I wouldn't suggest you do any of these exercises, but you could take that piece of paper, print it off, take it to your doctor and to your physio and get their opinion so she can feel empowered that she's got stuff she can do every day. And she also doesn't have to stress that she's never going to recover from this injury. Of course, this clinician doesn't have time to actually write these things. And there's a lot of literature that shows that the moment we leave the clinic, we forget what we've been told. Nothing to do with age. It's all very overwhelming, and there's a lot of new words getting used. So being able to have these tools that actually say, press a button for a summary that can then be emailed to patients. That type of thing, with a clinician's never going to have time to do, but now they can use these tools to do something like that. Anyway, it just made me think of my mum, and I did that for her on the weekend, and it related to this story, so I thought I would share it.
She's a lucky woman to have a daughter like you who thinks about her, Louise. But you're right. I mean, these are the things we can do. Let's use the tools where they show benefit. And you're right. Customized exercise routines for people with rotator cuff injuries that are evidence-based. And again, this comes down to us having that nationally sovereign curated health LLM model that has evidence-based information and not the latest and greatest crazes from Reddit. But there is no doubt that we can benefit by the use of AI. The question is, how do we design our system to make sure we get that benefit without getting all the consequences of some of the systems that are out there?
Yeah, that's right. All right, George, we're going to stick with the AI for our next story. And look, let's just say, I think it was just a matter of time before health AI ended up in the courts. Well, it now has a court date in America, of course. So a Florida pastor has sued OpenAI and its chief executive, Sam Altman. So Sam's getting sued from all angles. Elon's suing him, Apple's suing him. Now this Florida pastor is suing Sam in the Superior Court of California, alleging negligence And I think this is the phrase that matters, the unauthorized practice of medicine. So according to the lawsuit, ChatGPT told the pastor that his early warning signs were not something dangerous. It offered him diagnoses and treatment regimes, told him to just take it easy. And when he said this to the people in his church, and they thought he was crazy for not going to a hospital, it reassured him that they simply just didn't understand. Well, weeks later, the poor pastor was in intensive care with a massive pulmonary embolism. Now, this is very much an allegation. It's untested. We will report back the result of the court case. But OpenAI says its terms of service are clear that ChatGPT isn't for diagnosis or treatment and that newer models handle this situation far better than the model that was used at the time of the pastor's incidents. So look, this might be the first, but it is unlikely to be the last case claiming a chatbot's health advice harmed someone seeking guidance about a medical condition. George, this is the governance question, isn't it? Who's legally responsible when AI isn't accurate? We know when me as the clinician uses AI, it's my ass on the line as the clinician. But when the tool is just sitting there on its own and as a consumer I'm going to it, whose ass is on the line? And that is unclear at this stage.
Yes, the lawyers smell blood. Actually, in this case, they smell money, which to them is pretty much the same sort of thing. I read a quote on the internet. As a lawyer, you are taught to sue the people with the big pockets. And I guess OpenAI now falls into that space. So seriously, this is another great example of why we need better education about AI and not just rely on the fact that the legal disclaimers and the end user license agreement stuff that flashes on our screen, all care taken, no responsibility accepted. These are the sort of limitations. And we discussed it early on. If you can get a URL wrong and you can also get a pulmonary embolism wrong, that's quite a range of things they can get wrong in that space. Now, this story is interesting, I have to admit. I did have to have a little bit of a giggle when I read the story, and the New York Times did quite a good job in reporting it. But in this case, a man of faith placed far too much faith in a chatbot and not enough faith in the concerns of his church members and family. So it appeared that irrespective of how religious or agnostic you are, that it's easy to be swayed by the powers of AI. You would think someone with strong religious beliefs would probably rely more on people than technology, but again, classic example, the shiny thing paradigm, the fact that it's new, it's smart, it's posted all over the internet that this is an amazing tool, and the guy fell for it. And we saw here that the net result was pretty bad. Now, if his wife told him to go get a test and he didn't listen to her, then I can't blame ChatGPT for that. Even though I'm a doctor, if my wife tells me to go and get a test, and the reality is people who see you all the time have a better idea when something is wrong than probably ChatGPT does based on what you've typed into a chatbot. It's really important to understand that health is a multifactorial concept. And whilst AI is pretty cool, it doesn't have the answer to everything.
Yes.
Now, OpenAI has come back and said, look, this was based on ChatGPT 4, which had a tendency to sort of overcompensate to make the people feel relaxed. But the fact that its guardrails failed, so I think it's great that it's going through the legal case. The tools now need to become responsible for what they say. And we've seen that these tools are really starting to promote themselves as health tools. ChatGPT has ChatGPT Health. Claude has a Claude Health. They're making bigger and better and more grandiose claims. So therefore, we need to start thinking about how they're responsible for those claims. Now, if you're a shareholder in OpenAI and you realize that there's 100,000 Florida pastors about to sue you for $100 million each, that may make a dent in your financial returns. So I think that may be something that drives the play. But again, goes back to our question about AI readiness and AI education. We need to make sure we improve both of those things so that less of these things happen. This could have been a tragic circumstance. This guy could literally have died from pulmonary embolism. I have seen young, healthy men die from pulmonary embolism. So the fact that it missed something as potentially catastrophic as this is a big deal.
That's right. So there's certainly court cases going on regarding chatbots, which have given people advice regarding suicide. And there's a few court cases in the States around that at the moment as well. So we'll report back on the results of all of these things because it's very tragic circumstances where people have actually died or gotten bad advice and had a worse outcome as a result. Surely, as the tools evolve, they're going to get better, but they need to strengthen the legal provisions. Governments and courts need to to strengthen provisions around these companies. It can't just continue to be the Wild West, as Enrico said last week. So, yeah, I'm very interested to see how this lands. And I wonder when it'll be the first time we have an Australian involved in suing these companies for poor outcomes.
And the question, of course, is that, yes, there's the legal recourse, but the reality is transparency is the key issue here. Enrico touched on this really well in his presentation about the AI roadmap, that nationally sovereign, accurately curated, managed LLM that we're using for healthcare decisions, as distinct from the one we're using to determine what anime we want to watch on Netflix this afternoon, are two different things.
Absolutely. And the other thing, which is also a key feature of the roadmap here in Australia, is governments need to get organised and start educating the populace, not talking down to them, but just acknowledging people are using these tools. So here's some guidelines and things to think of and that sort of stuff. Governments need to do that because at the moment, it's either not happening at all, or if it is happening, it's a poor clinician who is faced in a very short consultation time window of someone coming in with inaccurate information, and they might be really concerned by what the chatbot has told them, and it's up to the clinician what they're going to say. And we shouldn't be putting that extra burden on clinicians, although I don't know exactly how we avoid it. But if we can actually improve people's literacy and criticism and improve their use of these tools, then that's something we really need to do. And just the fact that we're sitting back and just letting it happen concerns me greatly, even though we're a fan. Okay, George, time to wrap up the show. We've covered another 45 minutes. We get here so quickly. I always think we're going to cover more stuff and I never learn, and we can never quite cover it all. But anyway, it's been great being on the show with you today. Do you have any recommendations for our listeners?
The one recommendation I do have, as some of you would have heard me earlier this year on one of our podcasts when I was broadcasting from Athens, when I had gone to Greece to attend the Athens Digital Health Week, I've just received notification that it is being held again in 2027 in Athens, February the 23rd to the 25th, 2027, at the lovely Royal Olympic Hotel in Athens. I do plan to be there, and I'm putting out an invitation to anyone who wants to join me. It's quite an interesting event. A lot of the European entities are there. When I was there last year, Cyprus was just launching its National Electronic Health Record initiative, and they went with Open EHR, and they had some interesting discussions around that. So if anyone wants to come and join me in Greece in February 2027, I guarantee you'll have some interesting experiences at the Athens Digital Health Week, and then I'll show you some very interesting places in Athens to go visit as well for some fun times.
Oh, I love that, George. I'm going to be putting that in my diary. We should do like a study tour. We could even do a podcast recording from there. That would be fun. I've never been to Greece, which every time you talk about it, I'm like, I've got to get my ass there. It just seems like it'd be great, and great to go with you.
The home of medicine. That's where it all started. That's our reason to go back.
Excellent. All right. Thank you, George.
What about you,
And
Louis?
yes, I only have one recommendation, which we promoted it in the last episode, so I'll put a link to it in the show notes again. That team from Monash University are looking at clinicians' use of AI. It is a survey that is open globally. We have listeners in, 56 countries or something like that. So if you're a clinician or you know a clinician, have a look at the link in the show notes and please contribute to this survey, because we will be reporting back. We'll get the authors of the paper actually on the show to talk about what they find in their study. So clinician use of AI, survey open globally. Check it out.
So yeah, I highly recommend people to provide their input.
Thank you, George. All right, if you could please read us out.
Sure. So thank you all for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Emily Maher and the team at Pulse IT for their support. Big thanks to everyone for listening. Make sure you subscribe, follow and rate us wherever you get your podcasts. Visit pulseit.news to catch up on the news from Australia, New Zealand and Ireland. And if you're attending HIC in Sydney, come and look for Louise and I, and send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. Thanks, everyone.
Thanks, George. See ya.